This morning, we have a wonderful lineup of speakers. Both Professor Fokkens and Professor Dorscheid will emphasize the role of epithelial cell in regulating eosinophilia in the pathogenesis of diseases. This morning, we will focus on nasal polyp, rhinitis and nasal polyp, and allergic asthma. And without any further ado, I'd like to introduce our first speaker, Professor Wytske Fokkens. She is a professor of otolaryngology at the Amsterdam University, and she also has an honorary professorship in Patras, Greece. She's an extremely distinguished clinical researcher with over 500 published papers and memberships such as the founder member of Euphoria, or executive committee member of the ERS. She is the editor-in-chief of Rhinology and Rhinology Online, and associate editor of Allergy and Clinical Respiratory Journal. Without any further ado, Wytske, I'm going to turn it over to you. The floor is yours.
Thank you very much, Angela, for this very kind introduction. I will share my, I suppose I have to share my screen, don't I?
Yes, you can share your screen.
Yeah. Okay, well, thank you very much for this kind introduction. I'm very honored and pleased to join you in this webinar. Of course, I'm not a real expert on eosinophils, but I hope I can tell you something about chronic rhinosinusitis with nasal polyps and the role of the epithelium. And on the next slide, I would like to disclose my conflict of interest and thank AstraZeneca Amgen for sponsoring this webinar. It's very important to realize how united our airways are. It's very strange that we have a larynx that sort of cuts the airways in two. And also interesting that pulmonologists talk about the upper airways if they talk about the same part as we call the lower airways, the bronchi. I think the lungs we agree on, and the rest is different. So if you think about the upper airways, there is a very close correlation to the lower airways. Rhinitis is different forms of rhinitis are interlinked with the different forms of asthma, as you can see in this figure, and especially chronic rhinosinusitis with nasal polyps is very closely associated with late onset asthma and aspirin intolerance. Of course, in the recent years, we moved in our thinking from managing phenotypes, having a disease, we had a phenotype, and then we started a treatment and another treatment and another treatment, by now thinking much more in the way of endotypes and tailoring treatment to a certain endotype. And this is a figure from EPOS 2020, the European position paper on rhinitis and rhinosinusitis that's used worldwide in the management of chronic rhinosinusitis. Excuse me, emphasizing the importance of both the environment and the host to develop a certain endotype, the importance of barrier dysfunction, and eventually resulting in remodeling and a certain phenotype of chronic rhinosinusitis and/or asthma. If we think of airway epithelium, important to understand that it's the first tissue, of course, that encounters senses of danger, and especially the nasal and a little bit less the sinus mucosa is really the first part of the body that encounters allergens, bacteria, and viruses whenever we inhale. Mucus contains a lot of defense proteins, but that's also a physical barrier if it's intact, but also a very active player in the immune response, producing a number of mediator cytokines and chemokines, and we will look at that more closely. And probably the most important active part of the epithelium production are the alarmins, like IL-25, TSLP, and IL-33 that play an important role not only in the adaptive immune response, but maybe even more important in the innate immune response. These cellular and cytokine interactions are involved in allergic, but also in non-allergic airway disease, and also type 2 disease can, of course, be allergic or non-allergic. In chronic rhinosinusitis, epithelial barrier dysfunction has already been described about 10 years ago. This is a paper from Michael Soika, who showed in chronic rhinosinusitis with and without nasal polyps a downregulation of the expression of tight junction proteins like acetotoxin and claudin-4 and occludin. Of course, this is epithelial dysfunction is found both in chronic rhinosinusitis and in asthma, and these alarmins like IL-25 and TSLP and IL-33, as I said, play an important role in the innate immunity. In chronic rhinosinusitis, most patients with chronic rhinosinusitis with nasal polyps have type 2 inflammation. In about 80 to 90% of the patients in the Western world show a type 2 inflammation. In chronic rhinosinusitis without nasal polyps, there is a much more mixed type. It can be type 1 or type 3 or all sorts of mixes of that sort of inflammation. Also in chronic rhinosinusitis, like in asthma, innate lymphocytes has been described in the last 15 years, and different forms of innate lymphocytes have been described, type 1, type 2, and type 3, comparable to T cells. ILC2s have been described by my group in the first place about 15 years ago in the upper airways and later also in the lower airways. And ILC2s are able to produce a large amount of type 2 cytokines like IL-5, IL-13, and a number of other relevant cytokines after stimulation with the alarmins produced by the epithelium. ILC2s are significantly enriched in chronic rhinosinusitis with nasal polyps. This is that first paper 12 years ago from Anne Mjörsberg, showing a huge increase in the number of ILC2s, especially in chronic rhinosinusitis with nasal polyps. As of course has also been shown later in asthma. A big advantage of doing research with nasal polyps is that we have large chunks of diseased mucosa available after surgery to do research. We also showed in that period that there is a strong induction of TSLP, or TSLP strongly induces, strongly induced in nasal polyps, as is the production of IL-33. This is now extremely interesting because it gives a lot of new options for treatment in upper and lower airway disease. And at the moment, we do not yet for the upper airways have anti-alarmin treatment, like, for example, anti-TSLP, tezepelumab. We do do dupilumab, mepolizumab, and omalizumab available. For severe asthma, of course, we do now have tezepelumab, and for the upper airway, studies are ongoing, and they look very promising. And you see here the different biologics therapy for epithelial-driven allergic and inflammatory disease, and the enormous development that is going on, especially in the group of alarmins. Tezepelumab represents a new class of biologics targeting TSLP and blocking the inflammation on the top of the cascade, as you can see here in this graph. It is very interesting data coming from the lower airways at this moment, where it shows that it's able to manage all the different phenotypes and is irrespective of key biomarker levels, contrary to, for example, biologics against IL-5 or IL-4/13. You can see here the different options, the effect on clinical measures and the effect on biomarkers, from oral corticosteroids to anti-IL-5, anti-IgE and anti-TSLP. And you see the interesting effect of anti-TSLP on both symptoms, FEV1, exacerbations, and probably also type 2 low inflammation, and the effect on biomarkers like blood eosinophils, sputum eosinophils, and FeNO and IgE. Also, very interesting is the corticosteroid sparing effect of these type 2 biologic therapies. And you can see here for the different biologics how much reduction of oral corticosteroids can be achieved. And that's, I think, very important, because we recently had a very relevant, interesting study from the UK showing that even single or very seldom courses of oral corticosteroids already have significant impact on adverse events later in life. This is a unbiased indirect treatment comparison between tezepelumab, dupilumab, and benralizumab on exacerbations, FEV1, and ACQ. And you can see here that the larger here the area is, the higher is the ranking in the treatment on these different parameters. And you can see that for exacerbations, for FEV1, and for exacerbations and FEV1, tezepelumab was the most effective, although also dupilumab for FEV1 is ranked very high. But for asthma control questionnaire, actually, mepolizumab ranked the highest. If you think about factors that could favor individual biologics, you can see here a list of different options to choose from, where you can see that anti-alarmins like anti-TSLP have a number of characteristics that are different from anti-IL-4 and anti-IL-5. These are the first data with anti-TSLP in patients with nasal polyps. We really wait for the first study really done in nasal polyps. This is a study done in severe uncontrolled asthma with patients who had comorbid nasal polyps, and you see a a significant effect here, especially in the patient with nasal polyps, but also in the patient without nasal polyps. So you see here the effect on the SNOT22 and the different domains of the SNOT22. And we are extremely interested to see what will happen in the first study in a real chronic rhinosinusitis population without asthma. That study is done at the moment, and we wait for the results. So biologics give an enormous new option in treating chronic rhinosinusitis with nasal polyps, and of course also asthma. Here you see the asthma data, but for nasal polyps we can have a similar figure. What eventually we want to achieve, of course, is not only control of disease in the upper airways. We still mostly talk about control. We are already happy if we do not have to operate and do not have to give systemic steroids. But eventually, of course, what we want to achieve is remission and, if possible, cure of disease. And we really think that biologics will bring us, give us a new step in that treatment, in that options. And hopefully that will result in not any longer this severe, well, this is an example in rheumatoid arthritis, where I had a neighbor when I was a kid who had hands like this, very severe late rheumatoid arthritis, which of course now doesn't exist anymore. But in asthma, but also in chronic rhinosinusitis with nasal polyps, we see that patients lose their smell and have very severe sequelae of recurrent surgery and recurrent disease that we hopefully can prevent with management of these alarmins. In chronic rhinosinusitis, we just published this recent paper where we came with key definitions talking about control, remission, and disease. As for us, very new ways to think about the disease. Of course, in the lower airways, that is already a little bit more common, but I really hope that that also will happen in the upper airways. And there are quite some indications that actually that will be the case. Here you see the phase 3, the Synapse trial with mepolizumab in patients with severe chronic rhinosinusitis. And you can see that patients were treated for a year with mepolizumab, but after stopping the treatment here, you see that the nasal polyps remained on the same level. So there wasn't recurrence of nasal polyps in the 6 months after the treatment with mepolizumab. That really gives hope that we can reduce the disease forever. Also, dupilumab is able to modify the disease. Here is a study where in patients with aspirin intolerance, NERD, patient on baseline and after 24 weeks treatment with dupilumab, you see that at baseline, most patients reacted both in the upper and the lower airways to aspirin, and that after 24 weeks of treatment with dupilumab, most patients did not only had a reaction in the upper airways, but not in the lower airways anymore. And even 7 patients didn't react at all to aspirin anymore. So also an indication of the possibility of modifying the disease. Is that something that can only be done by biologics? No, definitely not. Here is a study of a small decade ago done in the UK, where they evaluated in a large national cohort of patients the period at what the patients were operated. And these patients were either operated in the first year after they got the diagnosis chronic rhinosinusitis. Then there was a mid cohort between 1 and 5 years, and patients that can only happen, I think, in the UK, that weren't operated 5 years after they had the diagnosis. And what you can see is very interesting, that the patients that had surgery directly after surgery, the patients all reacted the same. So the improvement in their SNOT score was very similar between these groups. But in the 5 years after that treatment, you see that the patients that were operated very early in the disease remained well. The patient that were operated 5 years after they got the diagnosis already declined again to almost the same situation that they had before. Not only the upper airways reacted in this way, also the lower airways. The patients in the early cohort developed far less often asthma than the patients in the late cohort. So that gives us the hope that treating with either biologics or surgery, but much earlier in the disease, when there is not a lot of damage to the epithelium and in the underlying mucosa, will hopefully give us the possibility to have remission and cure of disease. Finally, I would like to thank my team in Amsterdam, and I'm very happy to answer all your questions.
This was a really wonderful overview, Wytske. Thank you so very much. We have 2 questions from the audience, and I have a question on my own too. So let me start with the question by Zielfek. The question is, do the alarmins vary for different airways diseases? And he also, or she also has a second question, do these monoclonal antibody therapies have side effects like hypersensitivity? So if you could maybe answer the first one, is really an interesting question. I'm very intrigued.
Yes, well, I think alarmins have a very important role in the upper and lower airways. And of course, we knew a lot about that from animal experimental work, especially on TSLP, but also on anti-IL-25. There is, for example, a very interesting mouse model on anti-IL-25 showing that blocking resulted in total reduction of airway inflammation. But now with the treatment options that we have, the anti-TSLP that's already on the market and others, anti-IL-33 that are coming, our studies are going on at the moment, we see that these biologics are able to really block the inflammation very early in the process, and probably, well, in the upper airways, it's a little more obvious than in the lower airways, but also dupilumab already, anti-IL-4/13 already showed that because it's earlier in the inflammatory process that it had a better effect than anti-IgE or anti-IL-5 that's far further down in the inflammatory cascade. And you can really think that being able to block these alarmins so early in the inflammatory process will have a better effect, and not only in type 2 disease, but also probably in non-type 2 disease.
Yes, but philosophically, just, you know, if you care to speculate, depending on the type of the airway disease, is there a variability between the alarmin expression, or every time there is an injury, the same set of alarmins will be produced?
Yeah, that's a very interesting question, and I can speculate a lot, but I don't think we have a lot of data at the moment to actually show these differences. So at least I'm not aware of those. So I think at the moment we just do not know exactly how to tailor those different managerial options, and well, there's a lot to learn there to really be able to further tailor that to a particular patient.
Yeah, thank you. And the second question is regarding the side effects of monoclonal antibody treatments. Are there any like hypersensitivity and others?
Well, I don't think there is any indication to show hypersensitivity. Also, not a lot of indication to show that there will be autoantibodies. That was something we were afraid of in the beginning, especially if you want to reduce dose. We showed that for dupilumab, it is possible in the upper airways at least to significantly reduce the dose to say once every 2 months or so. So no, I don't think side effects in that way. For dupilumab, we know that because there is a huge production of eosinophils during the disease that is actually blocked, the entrance to the tissues is blocked by dupilumab. We see a temporarily increase in eosinophils, and that can sometimes be well, really worrying.
Yeah.
And we are always, of course, afraid of hypereosinophilic syndrome or another form of vasculitis by hypereosinophilia. In real life, it is a very, very small percentage. We now treated about well, between 400 and 500 patients in my department with dupilumab, and we saw a handful, less than 5 patients that really had so high, so not even vasculitis or so, but just very high eosinophils that made us worried and let us stop the dupilumab. So that's an issue. Further than that, I think until now the whole biologic seemed to be very, very safe.
Yes, thank you. So we do have a comment from Professor Delbert here. Nice talk, Wytske. The analogy of TSLP abrogation to TNF abrogation in RA is very important, and disease evolution is probably halted. So, so I think, yeah, thank you for this comment. Would you like to add to that, so that just to show that actually different alarmins may play different roles in different types of diseases?
Yeah, that's not my expertise. I don't know whether there are big differences in the different alarmins. So I do not have the answer to that question.
Yes, but thanks for bringing up the TSLP point and the analogy to TNF. I think it's very thought-provoking. Yeah. The next question is from Frida Young, and she's asking that it is interesting that biologics such as mepolizumab appear to be disease modifiers in chronic rhinosinusitis with nasal polyp, whereas in severe asthma, disease and inflammation seem to return after stopping biologics. Again, the disease modifying issue, yes.
Yeah, of course. We see the same with dupilumab, that we can reduce significantly can reduce those, but until now, of course, our experience is limited to a few years, and we now have dupilumab for upper airways since 2019 in Europe. So we now have about 4 years of experience, and we see that we can reduce, but we usually cannot stop. Of course, we now treat the worst of the worst, the really, really, really bad patients. And we started with the patients with an average, well, the patients in my department have been operated an average of 4 times. So you can imagine that if you start much earlier in the process, and of course now we are limited by the huge costs of biologics, but if that is over, and it will of course be significantly less in say a decade or so, you can imagine that if you start early in the disease, when there is not so much damage to the mucosa, that the options to really cut, to really stop the inflammation and stop the total disease are much larger.
Yes.
Also in the lower airways.
Right. But do you think there is a specific pathological pathway that would be affected in the nasal mucosa that is not affected in the lower airways, and that could be the reason why the disease comes back right away after stopping the biologicals in severe asthma?
That's a very difficult question to answer. I think in general that anti-IL-5s are more effective in the lower airways than the upper airways. And of course, they were earlier on the market, so it's probably also a question of more experience. But in the upper airways, the difference is huge. The anti-IL-4/13, so dupilumab, is significantly more, although we do not have comparative studies, but in real life, it seems that dupilumab is really more effective than anti-IL-5, and that seems different from the lower airways, and we don't really understand why that difference is. This longer effect is one registration study, so we definitely need more studies to show whether that effect is consistent. And looking at that difference, that actually anti-IL-5 is more, and anti-IL-5 receptor also more effective in the upper airways compared to the lower airways. I do not really understand why that difference is actually.
Yes, that's kind of a conundrum. So I also wanted to ask you, maybe it's a good point for my question, which is very similar to the previous one regarding the alarmins, and that's regarding the types of innate lymphoid cells that, although very few in numbers, but they are very troublesome, and they can produce magnitudes more mediators than other immune cells. Is there any variability in terms of innate lymphoid cell profile and expression between the various airways, upper versus lower, and or other tissues?
No, I think they're quite similar in. It's, of course, it's always a little bit more difficult to really evaluate tissue ILC2s from the lower airways. So very often that is, well, ILCs from the blood that have been stimulated in all sorts of ways in asthma patients. And you could argue, is that really the same ILC2 as that you see in the tissues? But I think the data that are available from asthma tissue, that it's very comparable to what you see in the upper airway. So I don't think that is that really helps us to understand that difference.
Yes, you know that in the GI tract, the ILC3s are predominant while in the lung is more ILC2s. Obviously, in both places, ILC1s are there in the largest number, but this difference between ILC3s and ILC2s could be very interesting. And I was just wondering if ILC3s are in higher or lower numbers in the upper. No.
No, in the upper airways, it's ILC2s. At least in the diseased upper airway, it's ILC2s is the main player.
Thank you. That's great. So we have another question. Thank you for the informative talk. Do you think the small subset of patients with chronic rhinosinusitis with nasal polyp treated with dupilumab who develop a hyper-eosinophilic syndrome would have gone on to develop that at a later date, irrespective of anti-IL-4 blockade? And do you think this subset of patients have an unidentified T-cell profile or T-cell clone that, if later identified, could guide future screening prior to anti-IL-4 blockade? I think this is a very interesting question.
Well, of course, you always think of, does a patient have an undiscovered EGPA? And that also happens if, well, 85% of my patients have asthma. So you can always have, and some have consistent systemic corticosteroids. So you can always have an uncovered EGPA, an unrecognized EGPA. On the other hand, I think almost all the patients where we had hypereosinophilia, it went away. Or in the few patients where we really had issues, we pre-treated them with anti-IL-5 because some switched to anti-IL-5 and then did fine. Some then had a recurrence of their polyps, but because the eosinophils had been brought down by benralizumab, for example, then you can easily overcome that period. But it's a transient problem. It's a problem of 6 months. So I do not think that there is the chance that you actually uncover an EGPA, or that you really have to do complicated measurements to profile the patient at the beginning is necessary, because usually it's just a transient problem.
Right, that's very interesting. And what do you think of the role of T cells in this, the driving role of T cells in this situation? I know that your talk was more focused on the innate aspects, but I think this question touches a little bit about the adaptive part.
Yeah, I really don't think that a really T cell driven type 2 inflammation no, I don't think in the upper airways that plays an important role.
Wow. Okay. Thank you. That's a very strong statement, because in asthma, I think T cells are thought to be kind of major drivers.
Of course, no, that's not what I mean, that they are not a major driver. But looking at that earlier question, would you need to do more extensive diagnostic things,
Right,
to uncover a potential? I don't think that is necessary, but of course T cells are extremely important also in the upper airways.
Yes, that's actually a very how to say, it's been always a tug of war between the adaptive and the innate systems, and over my long career, it was originally it started by showing the importance of T cells, and of course that's how the Th1 Th2 dichotomy came into vogue. I think now the pendulum is a little bit swung on the other side, and I think just like in your talk, you point out rightfully the significance of the innate system. And I'm not saying one is more important the other, but regarding this last question, I think it's a good thing to close by asking people to always think about the relative contribution of the adaptive immunity and the innate immunity to these pathogenesis aspects. Any closing thoughts, Wytske, that you would like to leave the audience with?
Well, I think you are absolutely right that maybe the pendulum now swings a little bit, maybe over the edge to innate. And of course, well, my interest is also very much in innate immunity, but we might find out in the coming years that also that is only part of the puzzle, and that we will swing back again to
Yeah.
understand which parts are totally not regulated in the immune part, so in the innate part. So well, we'll see.
Absolutely, absolutely. Thank you so very much. I'm giving it over to my colleague Roopa now, and thank you, Wytske. It was a really wonderful talk and conversation.
Thank you very much, Anja. Enjoy your day. Bye.
Bye.
Thank you, Dr. Angela Haczku. I'm pleased to introduce our next speaker, Professor Dorscheid. He is an associate professor of medicine at the Center for Heart-Lung Innovation at St. Paul Hospital, which is part of the University of British Columbia in Vancouver, Canada. At the hospital, he oversees the severe asthma clinic and serves as an attending physician in the intensive care unit. Additionally, he leads a research group. Professor Dorscheid's current research focuses on how the airway epithelium contributes to the development of inflammatory airway diseases such as asthma. Specifically, he is investigating the impact of abnormal injury repair cycles in the airway epithelium and asthma development. This includes studying how glucocorticoid treatment affects cell death in the airway epithelium, the role of glycoproteins in repairing the epithelium, and the mechanisms behind immune barriers in the airway. He has published widely on airway remodeling and optimal referral and management of severe asthma in Canada. Today, Professor Dorscheid will deliver a presentation on asthma phenotypes, pathophysiology of eosinophilic allergic asthma, and role of epithelium in eosinophilic allergic asthma. The floor is yours, Dr. Dorscheid.
Well, thank you very much for that kind introduction, and I thank the organizers and sponsors for this opportunity to talk. I noticed that there's 3 or 4 people on the participant list that have known perhaps me and my research program for a long time, and realized that quite often, 20, 25 years ago, I had to defend the role of the epithelium, and now it's quite the topic. And so what I'll try and do today is 25 minutes is just to kind of show you some of the interesting things that I think we need to focus on to optimize our patient care, but more importantly, to optimize our drug development, I think is perhaps a more important part for us to realize. Oh, there we go. So objective today, overview of type 2 inflammation in adults and address the role of the airway epithelium in the pathogenesis of asthma. Look at type 2 inflammation in a very quick overview. What is the pathophysiology of asthma? How do we get the phenotypic characterization from that? What's the role of the airway epithelium in asthma? And then truly, as our previous speaker did quite well, what are the role of biologics in asthma? Disclosure of my conflict of interest. I do a lot for a lot of different companies. I have Tri-Council funded grants as well in Canada. And to state that the slides are evidence-based and they're not promoting any specific products. I think this is a slide that most of us could realize as part of our career. Asthma is truly characterized by changes to the airway wall due to chronic inflammation. So if we go over here on the pie chart over here of the airway, truly the normal airway has significant changes as a result of chronic inflammatory influences. So whether it's smooth muscle hypertrophy, giving us airway hyperresponsiveness, fibrocyte proliferation, collagen deposition, which gives us irreversible changes to the airway wall, as well as mucus production. And it's these changes that we know generate then the symptoms, whether they're respiratory symptoms or airway obstruction, airway hyperresponsiveness, the exacerbations, and the progressive lung function decline. Pardon me. So it's not just structural changes to the airway wall, but it's also quality of life changes to our asthmatic patients we need to consider in this whole process. This, I think, is an important slide because I think it gets at not only the non-compliance that all of us clinicians know that our asthmatic patients sort of struggle with, but, if this is some work from Mark Fitzgerald from now, about 15, 16 years ago. And if you do patient perception or even doctor perception of their patients and how well controlled their asthma is, you'll see that everybody scores it pretty well. The patients believe that 97% of them are well controlled. Even specialists believe that 90% of their patients are well controlled. But if you use a validated questionnaire, you see that 53% of patients are uncontrolled. This is in a Canadian cohort of patients that he followed over many years. And their controlled or uncontrolled status is actually independent of whatever regimen they may be on, short-acting bronchodilators, ICS, SABA, ICS, LABA. So, as I mentioned, it's not just non-compliance that potentially plays a role here, but possibly the drugs that are available for the management of our patients aren't really addressing all the problems. Back in the 70s, when asthma was identified as an inflammatory disease and we focused on the eosinophil, we made huge advances in improving the quality of life and even reducing the mortality that was generated in pediatric asthma. But I think we still have a huge population that have unaddressed, uncontrolled symptoms, and perhaps it's because we need now to focus on a different cell subtype or a different organ within the airway. This is one representation. This is from Sally Wenzel many years ago, and I think it's trying to get at this idea that asthma maybe isn't just one process. It isn't just that it's allergic. It isn't just that it's eosinophilic, but that whether you develop your symptoms in childhood or you develop your symptoms in adulthood, you can actually have different inflammatory processes that we can then see as represented by different phenotypes. Whether it's in the child who are primarily type 2 driven, they have all these allergic-like conditions. But then in adult onset asthma, by and large, they're not type 2 driven. They have type 2 features, but they're not type 2 driven. And so we have to realize that, not all therapies may address all of our patient needs. This is just a neat little timeline. I started my PhD in the late 1980s when we were talking about type 2 and Th2. And I think it's important to realize that, as we learned more and more about the physiology and the pathophysiology of airways inflammatory processes, that we realized that it wasn't just the cells, but actually it was the cytokines that mattered. And that's why, like in 2013, they began to coin the term type 2 processes. I think from an asthma perspective, I have to focus on just type 2 inflammation predominantly. The upper airways has a lot of type 1 and a lot of type 3, as our previous speaker described. But certainly to realize that the focus on cells in itself may have been, very important early on, but now it might be too narrow. And then perhaps we need to realize that there's lots of cells make the same cytokines, and it's understanding that process that'll help us develop better strategies to manage our patients. So unlike the cartoon at the beginning, this is, an actual two, it's the morphing of two actual photographs of real airways. And these are very real changes within the airway. And I think that when we look at certainly the asthmatic side, you can see the amount of goblet cell, hypertrophy and the changes to the smooth muscle mass, and then the changes in the submucosal space. And that's where it was all focused on. But it's to realize that the epithelium, unfortunately, for far too long was viewed as merely a physical barrier. And the damage to the epithelium is being driven by the inflammatory cells that were in the submucosal space or even intraepithelial itself. If we look at this idea of type 2 inflammatory processes, this is now just, starting at the epithelium and working our way down. Of course, whatever we breathe in, there's particles. Those particles can either be allergic or non-allergic, meaning they can either generate an allergic process or a non-allergic process. To overstate it in a simplified manner, would say that every particle can cause microtrauma to the epithelium. That microtrauma now generates its own signals. The epithelium can generate IL-5 and IL-13 in itself, but also too downstream of the epithelium that has suffered this trauma. If it's a non-allergic trauma, that'll be your IL-2 stimulation, from the alarmin production from the airway. So truly, there's a large variety of epithelium-derived cytokines that can initiate these processes. It's important to realize that the alarmins, TSLP, IL-33, and IL-25, as our previous speaker described so well, generate, in itself, type 2 inflammatory signals. You get downstream IL-4, IL-13, and IL-5 signaling, which then generates, the antibody shift of B cells. You get eosinophilic biology. But then you also have the allergic stimulation, which comes through the T cells, or Th2, where you also get downstream IL-4, IL-5, and IL-13 signaling. As you move on kind of the right-hand side of this diagram, you can see that TSLP itself, as a specific alarmin, can have specific effects on some of the cells of the airway, including potentially being responsible for airways hyperreactivity. So, I think that for a long time we focused on individual cells. People often call diagrams like this confusograms, which I think is a little disrespectful to the airway biology. This is actually, I think, how complicated the airway biology is and why we focus on individual cells. Now we need to actually begin to integrate, where do these cells begin? And I think, or where do these signals begin? And I think that realizing that the epithelium in itself as the genesis, as opposed to a secondary, damage zone, is perhaps where we need to focus. This is just another little characterization, because I think it takes the complexity, of the type 2 inflammatory process to realize that clinically, we can kind of view type 2 inflammation in a different way. So certainly if you have predominance of IL-4, 5, and even 13% signaling, where you're driving the eosinophilic maturation, proliferation, and migration, we can have an eosinophilic pathway, or what we call eosinophilic asthma. Similarly, though, there's some people who have more of an allergic pathway, where the representation of their disease is being driven by, the mast cells, basophils, as well as IgE. And then there's kind of this last pathway. Some people can call it IL-13 driven, or the exhaled nitric oxide pathway, because, the FeNO is driven by IL-13. But I think that clinically, this is how we see asthma. We see it as different phenotypes being driven by the complexity of type 2 inflammatory processes that are initiated by these epithelial-derived cytokines. Allergic eosinophilic asthma, we can kind of break it down. I'm not going to break them all down, because I think the processes, are better viewed from the 30,000-foot view as opposed to channeling right in. But to realize that, even as demonstrated on this slide, the epithelium, as it experiences and senses the outside world, it can then generate alarmins when it has microtrauma. Those alarmins then generate, as I described previously, all these processes that generate either basophil, mast cell responses, eosinophil responses, and then generates the process that we see clinically within our asthmatics. Well, if type 2 inflammation is this process that's going to be predominant in the lower airways, how do we measure it? How do we follow it clinically? So I think that probably most, if not all, people that are participants on this webinar this morning realize that clinically what we follow is blood eosinophil counts, IgE, what is the level of IgE. It doesn't have to necessarily be specific IgE measurements, and exhaled nitric oxide measurements. So these are 3 clinically validated biomarkers that we can use to follow roughly the 3 phenotypes that are driven by type 2 inflammatory processes. What's important to realize, though, is that when we look at ISAR, the International Severe Asthma Registry, and you look at the number of individuals that have severe asthma that have these biomarkers, you can see that people can either have 1, 2, or 3 of these biomarkers, and that only 27% of severe asthmatics actually have all 3. More importantly, there's actually 12% of severe asthmatics that have none of these biomarkers. So it's not that these biomarkers are bad. They're actually, as biomarkers go, they're readily available. Most of them, they're easy to obtain. They're non-invasive predominantly. So as biomarkers go clinically, they're good, but clearly they're not measuring the whole process, because, we've got such variability. When we look at, the British or the UK Severe Asthma Registry, the mean blood eosinophil count in asthmatics is 330 relative to about 160, which is normal. Medium exhaled nitric oxide is 39. Normal is 20 to 25. And the IG level is 181, and their normal was 64. So, I think it's important to realize that clinically, we can follow our asthmatics, measure their inflammation with these biomarkers, but it's not necessarily telling the whole story. This, I thought, was a very interesting diagram that was put out by Chris Breitling and Pappy many years ago now. Well, I guess it was only 6 years ago. And it's looking at eosinophilic asthma, non-eosinophilic asthma. Is it allergic, non-allergic on the left-hand side? And then the non-eosinophilic asthma is the kind of the interesting beats, because we're just beginning to learn about it. The neutrophilics, the polygranulocytic. This is, UBioPred is working a lot on some of these phenotypes. But even in this diagram, it was acknowledged that no matter what the inflammatory process is in the submucosal space, the epithelium is abnormal. So if you look at the, the 1 o'clock part of this pie chart, you can see that where there's the polygranulocytic asthmatics, the epithelium is abnormal even in that category. So the question is truly, the inflammatory cell infiltrate, is that what's driving the epithelial abnormality, or is the epithelial abnormality itself the primary defect? This is some work that goes back now 25 years ago or more. Steve White, University of Chicago, and I was doing my postdoc with him. And that was the question we asked. We said, well, is the epithelium actually, more than just a barrier? And to be more than a barrier, it has to have more than just, ciliated cells and goblet cells. And so I used a strategy just using, lectins, which are like plant antibodies. And we identified over 20 different cell subtypes in the epithelium. So there's a rich number of cells that people now have moved forward with, and they've found ionocytes and a variety of other rare but very, very important cells in the airway epithelium. So realize that the airway epithelium in itself has all the cells necessary to be an immune organ, a very primitive potentially, but very nonetheless an immune organ. And so, I think that we are now learning some of the very important features of this immune organ and how it can coordinate and organize the inflammatory processes. This is a simplified diagram I've adopted from Donna Davies. This is now 23 years ago, this diagram. And even at that time, those of us that were working on the epithelium realized that you have a normal epithelium that's going to undergo normal injury. Wherever you have injury, you need inflammation to then promote repair. The concept at the time, though, is that this epithelium, if it cannot repair itself, it'll get stuck in this cycle of chronic inflammation. And when you get stuck in this cycle of chronic inflammation, whether or not, as this diagram suggests, it's being driven by, EGF ligands and EGFR abnormalities, but it's this chronic inflammatory cycle where we actually get dysfunctional repair, where we end up with all the changes to the submucosal space, to the smooth muscle mass, and even to the epithelium itself. What we started with a long time ago is we said, well, maybe one of the problems is that we're looking at diseased tissue, and we know it's diseased, but we don't necessarily know it's normal. And we did a lot of interesting studies using guinea pigs. And this was just one study actually showing normal airway epithelial repair. So we would actually just anesthetize guinea pigs, do a physical trauma to their airway, and then just follow the resolution of the injury to the point of reconstitution of a normal airway epithelium. And you can actually see in this process that, even after denudation, physically, you still have this almost like a cellular scab. The basal cells spread out and seal the trauma or the injury to the airway. And then it begins to have, a variety of, proliferative potentials to increase the number of cells that are there. You end up with an undifferentiated two-layer, undifferentiated multi-layer epithelium that after about 14 days, you now have an epithelium that is fully redifferentiated itself and looks normal. So this is the normal process, and we need to understand the steps in that normal process to figure out then what's going wrong on the asthmatic side or what's going wrong on the disease side. One of the molecules I've looked a lot at is IL-13. So I think that all of us know that IL-13 is kind of viewed as one of the demons of the type 2, cytokines and the type 2 process in asthma. But I'd counter that when we actually look at IL-13 in normal cells and normal airway epithelium, it's actually important, if not essential, for epithelial wound repair. It's just a figure from a paper now that goes back a few years. And on the right-hand side, these are air-liquid interface cultures. And right here on the bottom picture, you can kind of see on the right-hand side of that, the bottom image, that's where we've physically denuded part of the air-liquid interface. And within a few minutes, you end up with IL-13 expression. That's the pink that you identified. And IL-13 is generated through the whole reparative process. And you can actually measure and culture the release of IL-13. So to state that we don't actually need inflammatory cells to have type 2 cytokines, the epithelium itself is its own reservoir, some of the type 2 cytokines, the alarmins especially, but also IL-13 and IL-5. Just to add in one more data slide is to say that if I actually use an inhibitory antibody or chimeric antibody and I block IL-13, I can slow repair. And if I add in IL-13, I can augment repair. So we did a lot of variety of studies, and that suggested, at least in culture, the normal airway epithelium needed IL-13. This is some work looking at primary epithelial cells. You see a variety of, these are airway sections from autopsies of fatal asthmatics or individuals that died but did not have asthma. And when you look at IL-13 biology, there's actually two receptors, R-alpha-1 and R-alpha-2. And we know that they both signal. For a long time, it's viewed that only IL-13 R-alpha-1 was a signaling receptor. Unfortunately, in mice, they cut off R-alpha-2, and it's kind of a decoy receptor, or receptor that kind of binds the soluble IL-13 to lessen its effect. Pardon me, but certainly both R-alpha-1 and R-alpha-2 can signal. In normal or non-asthmatics, you can see that the amount of R-alpha-1 relative to R-alpha-2 would favor that there's way more R-alpha-2 than there is R-alpha-1. When we look at the asthmatic airways, though, that ratio is flipped. There's way more R-alpha-1 than R-alpha-2. And I have a little teeter-totter diagram at the end, but I think it's important to realize it isn't just the ligand that matters, but I think that it's all the downstream physiology and biology that matters. If I look at with either monolayer cultures of primary cells, or when we take the primary cells and grow them into air liquid interface, and we again look at this R-alpha-1, R-alpha-2 ratio, you can see that if it's asthmatic or non-asthmatic cells or asthmatic cells in culture, this flip in the ratio is maintained. So then when we do a very simple assay, so then if we think asthma is being driven because there's a primary defect in the epithelium, we should be able to manifest this or regenerate this in culture in the lab. And certainly when we look at the reparative potential of normal epithelium to asthmatic epithelium, or epithelium that we take from those people who suffer from asthma, asthmatic epithelium by and large cannot repair at the same rate, and there's a significant difference. So it goes back to that diagram from Donna Davies' group, and Stephen Holgate from many years ago, to suggest that if the asthmatic epithelium cannot heal, then that's a problem. It's not just a problem for particle access in to stimulate, directly or indirectly immune processes, but the epithelium itself, as an immune organ, it's always going to be producing alarmins and other type 2 cytokines that are going to generate this whole process unless we can fix the epithelium. This is a little teeter-totter that kind of my lab has generated over the past sort of 15, 16 years, and it gets this idea that a normal phenotype should overrepresent R-alpha-2 signaling to R-alpha-1, and asthma really is an excessive amount of R-alpha-1 signaling. So one way to conceptualize this then is if we could pick therapeutics that potentially can alter this teeter-totter and push the R-alpha-2 signaling back down, or maybe reduce the amount of R-alpha-1 signaling. So to what extent? So this is just one of the type 2 cytokines that we followed through, but I think that there's a lot that can be learned in terms of what is the primary normal biology of the epithelium, and then how does that drive the processes that we call, rhinosinusitis or asthma. I just want to go through a little bit of what but I guess the community, the larger community, what have we done with regard terms of drugs in the epithelium? This is Leighton and Leighton's paper from 1992, and I would consider this the most important paper demonstrating the role of corticosteroids, and more importantly, inhaled corticosteroids in the treatment of asthma. So you can see that this individual who was biopsied at time 0, and then 90 days later, after inhaling 600 micrograms twice a day budesonide, you now have reconstitution of what, from an immunohistochemical perspective or light microscopy perspective, looks like a totally normal airway epithelium. So we should be able just to give steroids to all of our asthmatics and they'd all get better. That's what this would represent. And I think that statement applies to a huge number of our asthmatics, but probably not the severe asthmatics. Steve and I, when I was doing my postdoc, we tried to take all of these as severe asthmatics that were symptomatic, even though they were on what were considered to be appropriate or normal therapies. So this is just one example from that registry that we put together. This individual was actually on 20 milligrams a day of prednisone, an ICS-LABA, and on an LTRA. And she was quite symptomatic. When biopsied, you can see that her epithelium is still quite abnormal. What's interesting is that just like the polyimmune asthmatic from Papian diagram that I showed earlier, there's actually a paucity of immune cells in this submucosal space, but the epithelium is still very abnormal, and she was still very symptomatic. In the bronchoalveolar lavage fluid, you can see that these are shed columnar epithelial cells. More importantly, these are ciliated columnar epithelial cells that show you the friability of this asthmatic, even though she was being treated per all the consensus guidelines, remains symptomatic because her epithelium is abnormal. In an animal model that Steve and I put together, it's the standard mouse model of OVA, oversensitization and challenge. And when we lavage these mice, you can see that early on they have a very high eosinophil count that kind of over time will resolve. So we followed them out to 14 days. If we gave them dexamethasone, we actually accelerated that resolution in terms of, yes, we gave them the OVA after they had been sensitized. If we gave them Dex, just like an exacerbation, it prevented or maybe eliminated the eosinophils from the submucosal space and the lumen. However, when we look at the epithelial cells in the same lavage, you can see that, even in those, mice that, that we gave Dex to, and thus there was not, any significant eosinophilia in the lumen or the submucosal space, they were still shedding large amounts of epithelial cells. So again, to realize that, we know that now that there's epigenetic phenomena in the basal cells of the airway epithelium, that can happen after one inflammatory event. And perhaps that's what we were demonstrating here now it was over 20 years ago. And to realize that the epithelium itself can be, abnormal in the presence or absence of immune cells. Formoterol is an interesting, long-acting, beta agonist that most of us, use. I mean, and I think that one of the, criticisms of the work that we're doing in the early 2000s is a lot of reviewers is like, well, we don't see this crisis. You're talking about this epithelial abnormality driving inflammation. But what this study showed is clearly that, formoterol is protective to the epithelium. So whereas we demonstrated quite clearly that steroids can be a primary injury source to the epithelium that then can drive its own inflammatory process, formoterol as a specific LABA can protect against that effect. So to realize that we already have drugs that can, we think they're just treating the inflammatory processes of the airway wall, but specifically some of them are very protective against, this injury repair process that's abnormal in the asthmatic epithelium. This is just data from Sigma. Again, too, it's looking at formoterol versus terbutaline, as reliever agents, right? So, the orange line is, the exacerbation frequency in those individuals that were using terbutaline as a reliever. If people use formoterol as a reliever, just formoterol, so now a long-acting beta agonist, there's a significant reduction in the exacerbation frequency. When you add on budesonide, the reduction is even further. So if it was just that formoterol, for example, was just a bronchodilator, it shouldn't be able to do this. But when we realized from the previous slide that formoterol actually is preventing injuries to the airway epithelium, probably independent of, we demonstrated that, inhaled corticosteroids can generate injuries to the epithelium, formoterol protected against that or reverse that. But it may very well be the same thing that formoterol may protect against, any or a lot of these microtraumas to the epithelium from any one of the variety of particles that we can breathe in. Again, our previous speaker did a phenomenal job in going through all of the biologics, and what the pros and cons are and how some deal with some phenotypes better than others. From my perspective, what we tried to do a long time ago is just, using the clinical biomarkers that are useful and have been validated. How can we use those to pick the biologic that is most going to benefit our patient? There's a few of us in Canada that do sputum inductions, and my lab and my clinic is one of those places. So this standard 2x2 table that initially was just blood eosinophil counts versus, serum IgE levels, we added in, sputum eosinophilia. Then using those three biomarkers, we attempted to try and come up at least with, kind of a 2x2 table to help predict, which biologic is going to help our patient the most. I think what's really interesting now is with the tezepelumab, in Canada, certainly it's considered biomarker free, whether, from we look at eosinophil counts or we look at exhaled nitric oxide and even seasonal allergies and IgE level, I can't really put it in the table. Whereas the other biologics, I can put in the table, kind of, but I would say that this table is too simplistic. And I think there's more we need to know about the biology of the asthmatic airway versus normal. And then how are these biologics, which are exquisite biological molecules, how are they interrupting, that signaling, and what does it mean for the other cells that are there? So I'd like to kind of, give my little summary saying that understanding the role of type 2 inflammation is essential in managing asthma. Jeannie even recognizes the idea that the biomarkers that we have are good, but they're probably not the best, and they're not, certainly from a research perspective or, managing our severe asthmatics, they're inadequate, but they're what we have at present. Biologics, by and large, were targeted against anti-Ig initially, then they were anti-IL-5 or anti-eosinophil. But now with dupilumab and tezepelumab, we have two biologics that truly are now one step closer to what I think is the problem, which is epithelial-derived cytokines and epithelial-derived inflammation. So directed therapeutics to target type 2 inflammatory processes have certainly improved outcomes. As our previous speaker explained quite well, and I think that, in the 90s, certainly we perseverated on FEV1s and we forgot that, well, our patients don't know what their FEV1 is. They don't know what their lung function is. They just know they're short of breath. They can't get to work. They can't get to school. So I think that certainly to realize that quality of living sort of outcomes and exacerbation frequencies are quite important. And I think that the biologics, but even certain non-biologics, even some of our inhaled therapies, we can target better than what we have been. The airway epithelium, I think I can't emphasize enough, it's not just a barrier that gets, injured, by the invading immune cells, where the immune cells are coming in without being pre-directed by the epithelium, for example. And the problem in the asthmatic is that injured epithelium just can't repair itself. An intact epithelium is anti-inflammatory. We need to acknowledge that it coordinates a lot of immune functions because it itself is a very primitive immune organ. Certainly in the asthma world, and I think in the otolaryngology world, this idea of remission is really important to consider. And I think that the reason why I kind of put it down as remission with a little question mark is, we actually have two biologics that, because they are actually directly addressing the epithelium, we may actually have a couple of biologics at this time that may be able to push remission. And I think that's a hope that we can potentially give our asthmatics, like the rheumatologists gave to their RA sufferers many years ago. So at that point, I'd just like to say thank you, and I'll field questions. Thanks very much.
Thank you, Dr. Dorscheid. Thank you for sharing your work with us and sharing your knowledge, and especially emphasizing on importance of epithelium in controlling asthma. So I kindly ask participants to type their questions in Q&A chat box. So far, we got one question regarding epithelial shedding in mice with and without DEX, wondering whether there is any baseline shedding in normal mice. That is, how close to normal is the shedding observed at the last time point?
So that's interesting, and there is shedding at baseline. I think that, mice, like humans, we breathe in, and there's always going to be the accumulation of these microthrombus that I was talking about. The important thing is it's like proportion of cells. So, in a human bronchoalveolar lavage, very rarely will you have epithelial cells other than, alveolar macrophage. We call normal less than 1% of total cells should be airway epithelial cells, truly from the conducting airway and not from the alveolar space. And so in the mice, it's no different. I think we said with 0.8% of total cells, and we considered that normal. So again, to realize that, very few things are actually 0% or 100% in nature. And so there was a baseline amount, and in that mouse model, it exceeded that baseline amount. Yeah.
We have our next question from Jessica Most. Thank you for a wonderful talk. Do you think that the abnormalities in the respiratory epithelium lead to differing types of exacerbations? Does this make a difference on how you would choose a biologic?
Yeah, that's a fascinating question. I think, in the 90s and the early 2000s, we looked at ABPA, for example. And there were studies that said that ABPA was, not significant, linked into the pathophysiology or the pathobiology of asthma. And I think that there was a lot of reasons why that conclusion came out. It was kind of how we defined ABPA at the time. But there's also just huge heterogeneity. So if we just look at those asthmatics that we think have asthma and ABPA, I think that, and sort of, again, also the severe asthmatics that have colonization of non-tuberculous mycobacterium, just as two examples. So I think that, those two microbiological triggers are going to give us different inflammatory processes than somebody who, lives in downtown Vancouver and is breathing in construction and concrete dust, 24 hours a day, or that individual who has very specific seasonal allergens. So I think that, different triggers are going to give us different exacerbations, but there are also going to be different epithelial abnormalities, such as this question, is getting at. And I think that we're just beginning to catalog and identify, these differing epithelial abnormalities. And I think that, now that we have all, a lot of very differing techniques, single cell analysis and things to that extent, it'll be very interesting to see how, as we catalog epithelial abnormalities, to what correlate then do we identify a clinical phenotype? Oh, and does this make a difference in how I choose a biologic? It certainly does. I think that, if we have an abnormal epithelium and we think that that in itself is driving the process, Tezspire and dupilumab, both I think are epithelial-directed targets. Mepolizumab, some people believe because of the IL-5 that the epithelium makes, it may also be epithelial-targeted. So, if you have, like these microbiological processes that are driving inflammation, yeah, that's going to be a primary immune defect of the epithelium. So, and that's just a very sort of simple way to answer a question, which I think is amazing, but also quite complicated because we haven't characterized all the, abnormalities in the epithelium yet.
Our next question is, given the role of the epithelium barrier in both T2 low and T2 high asthma, is more research targeted at specific transmembrane proteins, example, OR, MDL3, E-cadherin, etc., warranted?
Yeah, yes. I mean, I think that, the more research we do, the more knowledge we acquire. And to get at the previous question, we need to catalog these epithelial abnormalities and realize that there's going to be a whole variety of abnormalities. We can probably group them like UBioPred is doing with their stuff, where they realize that lots of abnormalities are going to create one clinical phenotype. So I wouldn't, disregard or change research because, we can already say that, some of these junctional proteins are important. They probably all are. But I think that, TH2 high and TH2 low, that may not be the issue, but really epithelial abnormality, and then asking the question why. And certainly, proteins like E-cadherin and all those are quite important in that process.
Thank you. Our next question is from Krishna Chibba. Regarding the unique protective effect of formoterol versus ICS plus formoterol, does the mechanism of that benefit to the epithelium involve preventing epithelial cell extrusion and crowding?
Yeah, that's another fascinating question. If I were to answer it as a science geek momentarily, when we grow these primary cells in culture and monolayer, they heap up. So they certainly, even in culture, we can have this altered physiology and altered analysis of these cells because of, this extrusion or crowding, which has been described by, some researchers very well in the past 10 to 15 years. ICS increases proliferation. Formoterol has no effect on proliferation. So, I mean, it's interesting. Our research would suggest that formoterol is protecting against an ICS-induced apoptotic activation in the epithelial cells. But I would have to say that there's probably multiple pathways by which, the ICS formoterol combination versus formoterol are providing benefit. And I wouldn't exclude extrusion or crowding as being one of those mechanisms.
Our next question is from Dr. Angela Haczku. I'm wondering how important surfactant protein A and D are in the anti-inflammatory nature of the epithelium.
Another excellent question. I had one really dedicated undergraduate student who worked 3 summers in a row and then went on to dentistry, and I was crushed because she was a phenomenal researcher. But she demonstrated the role of surfactant A and D as anti-inflammatory, and it's interesting because you can put the surfactants in parallel with and interacting with the IL-13 pathway. So again, too, it just adds to the complexity. The epithelium has all the tools it needs to perceive its outside world, and then it has its own rheostat. Do I not respond to this particle and its injury? Do I respond to it, and with what mechanism? So certainly A and D are quite important in an anti-inflammatory role for the epithelium. And it's not just because because we don't have microbes in our model. So so I think that yes, the surfactant proteins are they're anti-inflammatory, they're anti-infectious, antibacterial. There are lots of things, but I think that for the epithelium specifically, they can be anti-inflammatory. Yeah.
Thank you. Our next question is from Jakub Novosad. Thank you for the extremely interesting talk. What do you think will or may be the role of the biomarker periostin in terms of the detection of epithelial disruption or processes like EMT or fibrosis? And another question is what its role in predicting anti-TSLP efficacy?
So periostin, on one level, has been validated as a biomarker to be able to select high type 2 inflammatory asthmatics. So, the problem is that the therapies that it's been, I guess, utilized for, the results, even though positive, were kind of underwhelming. But it shouldn't reduce the potential role for periostin. We just need to figure out how periostin and other potential biomarkers that still exist within the research realm are going to be able to help predict better the different types of epithelial abnormalities. And then the next step would be then how would it predict the therapeutic that's best going to address that abnormality? So an important question, but I don't think we have enough data to answer the specific questions that were asked.
So our last question is from Ron Chan. In your view, how IL-13 works with its upstream trigger, alarmins, to regulate the homeostasis of airway epithelium in asthma?
Yeah, it's interesting, right? Because, nice question. I think sometimes we view these inflammatory cascades as too linear and maybe, not very, interrelated. But we know that when you have microtrauma to the epithelium, whether it's chemical, by a cytokine or something like that, or physical perturbation, such as mechanical wounding, or when you have a big particle come in and it kills a bunch of, epithelial cells, we're going to have alarmins and IL-13 made at the same time. And then downstream from that, they're going to interact where, the alarmins are going to take your ILC2 cells and they're going to have more, 4, 5, and 13. 13 is important to repair the epithelium, but it does all these, what we consider to be deleterious or damaging effects, by ramping up the immune process. So yeah, I know that the alarmins are viewed as upstream, but if we're going to look at epithelial-derived cytokines, the alarmins and 5 and 13 come at the same time. Are they all equal? No, they're not all equal. I think the alarmins are very important and probably the most important in generating the inflammatory process. But that IL-13 and a variety of other cytokines are very important in regenerating the injury to a normal epithelium. So, yeah.
Thank you, Dr. Dorscheid. To ensure we stay on schedule, I kindly request you to take rest of the questions offline if possible.
Totally. Thank you very much.
Thank you for your understanding. I would like to extend my sincere gratitude to both our esteemed presenters today and all the attendees for their participation and valuable contributions throughout this webinar. I'm pleased to inform you that the full recording of today's session will be made available on demand for those who may have missed any part or wish to revisit the content. Furthermore, I encourage all attendees to keep an eye out for the post-webinar evaluation, as your feedback is immensely valuable to us in continued improvement of our future events. Also, I would like to thank our sponsor for this webinar, Amgen and AstraZeneca. Once again, thank you all for joining us today. We look forward to connecting with you again soon. Have a nice day.